is going to record it. Yes, fantastic. Thank you so much. And I'm just going to share my slides. So you will get copies of these slides because we've got loads. I've put loads of hyperlinks on them. Sorry. Right, can everyone see that?
Yes.
Fantastic. Thank you so much. So I just wanted to go over some learning outcomes at the start of the session, and forgive me, I do a lot of university teaching, but I think it's really nice to know what we're planning to cover. So this is very much an overview of project management specific to the NHS or to general practice. I hope nobody's here from expecting project management in industry. I'm going to signpost you to a lot of suggested resources, which might seem a little bit frustrating at times, but I promise you it's really short, and the resources that I'm signposting you to, I use all the time. And then I'm going to give you some Kate tips. So my preferred project management tools that I use all the time. And I think it's worth just saying who I am, because who is Kate, telling you what to do, telling you how to project management. I have worked in the NHS for longer than I care to remember. I originally started off doing the NHS Management Training Scheme, and then I worked in NHS complaints and litigation for a couple of years, which was really interesting. I think complaints is a brilliant way to really get to know about an organisation. My chief executive at the time called complaints the gold dust of an organisation. I think in terms of project management, they can often be a really good starting point for quality improvement and change. I also did a master's in health service management and policy at a health service management centre in the University of Birmingham. And then I retrained as a respiratory nurse. And my kind of turning point for that was a emergency department nurse of the department that I was managing, who told me that I couldn't give a patient a blanket because I wasn't a nurse. So I don't really like being told what to do. So I retrained as a nurse. And I've spent my time doing a lot of project management and quality improvement, both as a nurse leader, and a manager. And more recently, I've moved into research. So I did my PhD looking at patient experiences of treatment in chronic obstructive pulmonary disease and lung cancer. And I now do a clinical academic post. So I work part-time for the NHS in a really lovely role, working across the Southwest with general practice nurses, encouraging general practice staff to take part in research. And then in my role in the University of Southampton, I'm actually doing a quality improvement project where we're upskilling general practice nurses in respiratory skills. So a combination of my management, my research and my nursing. Like I say, feel free to stop me at any point, and I'm not meaning to go on about my qualifications. It's just I think it's sometimes helpful to know that I have both practical experience but also some academic experience. I have done a number of project management qualifications as well. So I've done Prince 2, and I've done Introduction to Successful Programs. I have to say I didn't find either of them particularly useful, certainly in relation to the NHS, which is why I really emphasise the resources that I'm going to share with you today, rather than spending lots of money on very expensive and quite irrelevant programs. So project management, why bother? So Winston Churchill said, those who plan do better than those who do not plan, even though they rarely stick to their plan. And I think that's really important. So having a plan is good. Sticking to your plan is good. But sometimes it's really important to know when not to stick to your plan and why not to stick to your plan. Right, not going forward for some reason. Okay, and this is my key project management questions. So I think there's three things that I really, if you don't take anything else home with you today, these three questions are so important. So do you and your key stakeholders know exactly what you are trying to do? And I think it's really important. Often we know what we're trying to do, but your key stakeholders, so that might be your clinical teams, it might be your administrative teams, it might be the commissioners, it might be the social care, it might be the third sector. They might have completely different understandings of the project and the project outcomes. So spending a lot of time at the start of the project working with your key stakeholders about the key aims of the project is absolutely vital. How do you know that what you're doing will make a difference? So being really clear about your aims and how you measure the aims and whether or not that makes a difference. And I also think it's really important, going back to the Churchill quote, to think about your project and its evolution. So I worked on a project during COVID, which was all about face-to-face working with general practice. And when we had COVID and we couldn't go into general practices, we moved it online. But our project fundamentals and the way in which we measured the project stayed exactly the same. And we worked with our key stakeholders to make sure that everyone was on board at the start of the project. And actually, that was so important to the success of the project. And I think most importantly, it's the kind of so what. So will the project work when you've left? So often projects in the NHS work because we have very enthusiastic clinical and administrative staff undertaking the projects and the project management. But when they leave, the project falls to the ground, and it's thinking about, I think that's probably the most difficult thing in terms of project management, making the project business as usual. So I'm going to direct you to this set of resources a lot, and it's NHS project management resources, and I've put the links in the slides, which, as I say, will make sure you have a copy of those by the end of the presentation. I don't like you to have them before the presentation because I think that often you just look at those and don't listen to me waffle on. And so the 6 steps of project management, I think, are really simple, and I'm just going to talk you through them and give you some suggestions and signpost you to various resources to think through them in a bit more detail. So obviously, starting out, defining and scoping your project, measuring and understanding, designing and planning, implement, so actually doing it, and then that key one, sustain, making it big business as usual. So the first thing to do is to establish your rationale for your project, and there's a really nice link here around identifying frustrating problems, and it's really ensuring that you get your, so it might be a group of people together in a general practice, for example, and you're thinking about how to make appointments more efficient. So you essentially get a group of people together in a room and sort of process map the problem or process that you're thinking about, which helps you think through the project itself, but also gets you to buy in engagements with your colleagues. So it's a combination of the two. In terms of define and scope, there's so much project documentation around, and some of the project management, the really formal project management courses, so Prince 2 and Managing Successful Programs, are really, really documentation heavy. But I think these 3 pieces of documentation are the only 3 that you actually need, with action logs as well, which I'll come on to later. But these to me are the 3 key bits of project documentation. So a project charter or a project initiation document, so it's literally just setting out what you're going to do and how you're going to do it. And I've given you a link to a template for a project charter. It's a really nice way of setting out your project plan in a logical flow. The second thing is something that I constantly come back to, and it's stakeholder mapping. So knowing your stakeholders and knowing their level of power and influence over your project is so key. So, different stakeholders will have different influence over different projects. So, for example, a very clinically focused project in a hospital may well be driven by nurses, doctors, physiotherapists, and other allied health professionals and pharmacy professionals. A project where you're looking at service change and commissioning, you might well need to get people from the Integrated Care Board into the steering group at the start. If you're thinking about conducting a research project, you may well need to get your university stakeholders on board, and different stakeholders will have different levels of influence. So what I like to do is write down all my stakeholders and think about their impact on the project and how to engage stakeholders. So I'm thinking about a project that is ongoing at the moment. It's the project that I was talking about, which is a project looking at improving respiratory skills in general practice nurses. And we've got 2 different groups. So we've involved stakeholders from the start, and we've got a small working group which consists of the key people who are actually doing the project. So people in the general practice who are delivering the training, also a patient representative, and a commissioner. And then we've got a larger working group that includes national stakeholders, so people who commission respiratory medicine nationally, and people from charities such as the Association of Respiratory Nurse Specialists and Asthma and Lung UK. So different stakeholders support the project in different ways. And really importantly, it's important at the start of the project to identify potential risks. So again, thinking of a project that I'm working on at the moment, it was very much identifying the fact that nurses often struggle to get released from general practice and how we might best support that. So you think about the risks, you write them down, but you also think about risk mitigation. So thinking about the risks from the start, and that's something that you can involve your stakeholders in. All of these documents are what we call living documents. So they're not set in stone. They're very much intended as a support to your project. But they're also a good way of documenting to your senior responsible officers. So that's the Prince 2 terminology, but it essentially means your line manager or anyone anyone that has a stake in the project. That might be somebody who's funding the project. So, for example, in my project, I'm having to report back to the funder every 6 months, and it's really helpful having this project documentation so that my reporting process is really easy, because you take what you've started with and you're updating it. So that's define and scope. And measure and understand. And I think this is something that we often forget in the NHS. So how do we know that what we've done, what we've set out to do has made any difference? And what measures are we going to use? And again, this is something very much to involve your stakeholders in. It's really important to think about data that is currently available, and your integrated care boards can often help with that. There's also, and I don't know whether you've come across this before, but there's public health data that's freely available to anyone, public health information at your fingertips. So really thinking about the measures that you will use in your project, why they are important, who is the person that's actually responsible for delivering the measure, and ensuring that everyone is clear on the definition of the measure. So you can see that I've put here, spell it out very clearly in words. So be really, really clear about your definition. And I think on the collection part of things, I've already talked about looking for data that's already routinely collected. And if you work in primary care, which I'm sure many of you do, it's great having electronic health records, because there's a lot of data that's routinely collected. But thinking about who is responsible for collecting that data, and who do you need to liaise with to ensure that the data you need is actually measured, and measured in the way that you want it to be measured, and is then available to be presented in the right way. And there's often a lot of people that can support you with this. So my preference for data measurement is always qualitative, because I sit much more happily with words than with numbers. So I tend to simply ask people. I often ask people how they feel about something. So again, I'm sorry to keep going back to my own projects, but I think it's useful to have these really concrete examples. So, for example, in the project I'm running at the moment, we are evaluating it in a number of ways. So we're doing questionnaires, which are binary. So the questionnaires have yes, no responses. So you have numeric, quantitative data available from the questionnaires. But we're also doing focus groups and interviews with the people taking part. So we'll have both quantitative and qualitative information available. And I am the person that is responsible for collecting that, and another person is responsible for actually delivering on the training. So we've got very clear division of responsibilities, and we actually had to write a protocol for our projects. So similar to project initiation documents or project charter. So design and plan. So this is the other piece of documentation that I like to use alongside a project charter, and it is really, really simple. So it's taking the objectives that you've clearly set for yourself and putting them into an actual action plan. So I mean, it couldn't be more simple or self-explanatory, and I feel slightly embarrassed going through it even, but I will. So you literally write your objective, and then what I try and do is think about the actions that I will need to take, or people in my project team will need to take to deliver that objective. So you write them down as steps, and then you write down the names of the people who are going to deliver it, and you write down the date of when you anticipate it being delivered, and it always slips. And then going back to risks, you write down any possible issues against each of the actions. So that for me, along with the project charter, the stakeholder mapping, and the risk assessment, those are the 4 key documents that I think are absolutely essential in effective project management, and are just so useful in terms of ensuring that everyone is clear on what's going on in your project. So implement. I don't know whether anyone's come across Plan, Do, Study, Act, but I have used this ever since I was a baby NHS manager in my first ever role, which was working in A&E, and I started in '99, and the new Labour government had just come in, and they were really hot on the 4-hour waiting target in A&E, and I think we had on average about an 8-hour waiting target. So we used Plan, Do, Study, Act cycles to bring our waiting times down from 8 hours to 4 hours, and it's a really, really effective way of project implementation, and you can use it for so many things. And again, it's a cycle, it's a living document, it's iterative. So you don't just do one round of Plan, Do, Study, Act, you do multiple rounds, and it can be on really, really small things. So you could Plan, Do, Study, Act how to have breakfast as a family if you wanted to. So, for example, say your objective was we all want to have breakfast together at 8 o'clock. Then you think, how am I actually going to do that? So I'll need my husband, my daughters, and where are we going to have it? We're going to have it in the kitchen or the dining room, and then I'm going to use quantitative and qualitative measures. So I'm going to count how many times we have breakfast together, but I'm also going to talk to my husband and my teenage daughters about how they feel about having breakfast together. And then you implement it. So you make your changes. You're all having breakfast together at 8 o'clock, and I'm documenting the fact that it's really difficult to get my teenage children out of bed at 8 o'clock, and they don't want to eat porridge. So that's a challenge. And then I'm analysing my data. I'm thinking, oh, okay, so we actually managed, out of 7 days, I actually only managed 1 day to do it at 8 o'clock. So that's not great. But I have noticed that my daughters don't like porridge, and actually they are much better off eating in the kitchen because they don't like to bring their bowls through to the dining room. So I think, right, I'm going to move breakfast together on to a Saturday, and we're going to have we're just going to have breakfast together on a Saturday at 10 o'clock, and we are going to have pancakes. And then I begin the cycle again, and I say, now, did that work? Every week we have breakfast together on a Saturday. So I hope that's clear. Sorry, it's really difficult to see anyone because I'm on slideshow, but do feel free to jump in if you've got any questions. But I absolutely love Plan, Do, Study, Act cycles. I use them all the time, not just in project management, but in daily life. That probably makes me quite sad, but I enjoy them. And then I think one of the most difficult things is sustain. So how do we actually make a project, a quality improvement, business as usual in the NHS? And I think the NHS is quite an odd beast because we are often very resistant to change, and quite rightly. I mean, change isn't always a good thing, and we can get I don't know about you, but having worked in the NHS for 20 years, I've gone from like primary care groups to primary care trusts to CCGs to primary care networks, and it can just feel like we're constantly changing without any clear plan. So I think it's important to be really clear about something that sorry, I don't think I put in, like, I haven't put in the reference for this, but I will do when I send out the slides. So Trish Greenhalgh, who is a GP and a professor of research, professor of primary care, she has done a lot of work around the elements that support the sustainability of a project. So I think it's really important to recognise that not all projects work. So we often start off with the assumption that what we're doing, our quality improvement, is going to be better than how we deliver something currently. And sometimes it isn't. And it's really important to be clear about that when that happens. So don't persist with something that's not working and force it on people. Compatibility with current systems and values. I think if you've brought your stakeholders on board with you, so started off involving people at the start so that they feel that the change is their idea and they have ownership of it as well as you, and it isn't imposed upon them. I think that's really vital. So if you think about the breakfast idea again, if you're forcing teenagers to get up at 8 o'clock, that's likely to end in tears. How simple is the change, and how simple is it to implement? And a part of our job as project managers is to make change as simple as possible and to support implementation. And then this really vital thing, so ensure that we test what we're doing before we fully commit to it and fund it. And again, I think we're really bad at doing this in the NHS, and I'm going to talk a little bit about that in a bit more detail. You'll have to forgive my cynicism. And how observable is the change, and particularly the impact of the change? And I always think in terms of impact, I try and think about quality and cost. So, is this project going to benefit patients, professionals, or the healthcare system in terms of improving quality? And is it going to reduce cost? And I know a lot of project management and management appears to be about cost, but we are a tax-funded system, and we have a finite pot of resources, and it is our responsibility to ensure that changes are economic where possible. But sometimes they do cost more. Quality can cost more. So the thing I particularly like, my particular, as well as PTSA cycles, is theory of change. So this is explaining not just whether an intervention works, but how, why, when, and where. And the reason for that is so important because, and this is where my cynicism arises. So I think the way that service change often happens in healthcare is that a whole load of people are sitting in a room. In my head, they're sitting smoking cigars in a some kind of old-fashioned club, and they decide, yeah, that sounds like a brilliant idea. So, for example, today I was hearing that Ofsted is changing its one word rating. You know, Ofsted in schools is changing its one-word rating to a report book style rating. And I heard some poor primary school head in on the radio saying, yeah, that's all well and good, but are we going to be bashed with many sticks instead of just one stick? So yeah, I often think these ideas are sort of fashioned without any kind of reference to anyone that actually works in the system. There's a lack of clarity to the processes that are being targeted, so a lack of understanding of the aims of the project, but also some of the assumptions that are being made. And there's no attempt to test the change systematically or measure it. So that emphasis that I was talking about earlier, the emphasis on measurement. And there are many unintended effects of change and unintended effects of measurement itself that that often occur. And one of the benefits of working in the NHS is that change should benefit not only your own sort of micro organisation. So in a hospital, it might be a ward. In a general practice, it might be that general practice. It should benefit the wider system. So, you know, a change should not stay in a ward. It should spread across a hospital and potentially even nationally. And again, in general practice, it shouldn't just be limited to one general practice, but it should spread across the primary care network and integrated care board, and again, potentially even nationally. So it's really important to be really clear about what your change is and why it's worked. And Mary Dixon Woods is a fabulous health service researcher who's done a lot of work around the theory of change and logic models, which I'm just about to go on to talk about in a bit more detail, because again, I think they're a really useful project management tool. So logic model is in its simplest version is just simply a graphic display of your project. So it looks at the resources that are going into the project, the activities, the aims and the activities that you intend to go through, and the results of the project. But crucially, it also thinks about your assumptions. So what assumptions are you making about the project and how the project is going to work? So, for example, an assumption that you might have might be that nurses are motivated to take part in educational programs, which may or may not be true. In the case of my teenagers, I was thinking, yes, they're going to love having breakfast with myself and my husband, which may or may not be true. So it's just thinking about the assumptions that you are making and trying to make them really explicit. And again, a logic model is a living document. So your assumptions may change. So you might find, oh, my teenagers hate having breakfast with me. My nurses don't want to go on a respiratory training program. So your assumptions may change throughout the project, and then you have to come up with new assumptions. So you can use a logic model to support understanding of how and why a project may work, to highlight the gaps between assumptions about what project will do and the actual outcomes, and to orientate and help stakeholder buy-in. And it's really important, I think, it's really important to involve your stakeholders in the development of a logic model. So to sit down with them and go through how you're forming your logic model. Sorry, just checking the time there. So using a logic model in quality improvement, you can help it can help you check milestones. It can help you reflect on whether you've set out what you set out to achieve. And it can help you communicate program success or program failure and program challenges, all of which is really important in terms of learning. So this is what a logic model looks like. So you start off, it's essentially putting all the bits and pieces that I've talked to you about throughout the past 45 minutes into one sort of plan on a page, if you like. So you look at the context or the need for the project. You look at the resources and the inputs that you have for it. So that might be, I don't know, it might be the money that you have to do the project. It might be the stakeholders that you have. It might be the fact that you have support from charities. Then you look at the activities. So what are you actually going to do? And again, thinking about your action log. So being really clear about what those activities are, and in your action log, who is going to do them. Thinking about your outputs. So people often get confused between outputs and outcomes. So the outputs are the products of what your project is producing. So in my project, the upskilling of general practice nurses, we are producing some written documentation. So a sort of course book, if you like, for respiratory nursing in general practice. But we're also producing nurses themselves who are skilled in respiratory nursing in general practice. And the changes are different. So the outcomes are increased confidence in delivering respiratory nurses, in delivering respiratory care for patients in general practice, or they might be more even deeper than that. So they might be improving patient care, and impact is looking at the impact. So does the project impact on just your micro organisation, or does it impact more widely on other PCNs, other groups? So that was all that I wanted to cover in my sort of chalk and talk presentation. I wondered if you had any questions about anything that I've covered. I can see there's something in the chat. Okay, Charlotte's got to jump off for a practice meeting. Fine. Any questions? I've given you lots of information in the past 40 minutes. So you may just be reeling with it and thinking, oh my goodness, but any questions, comments? Or have you all gone somewhere else? Does anyone have experience of using any of the tools that I've talked about?
I was going to leave it to the clinicians, but no one's saying anything.
Thanks, Judith. I wasn't sure if anyone was still there.
I'm actually a project manager new to the health service. So and I've done prints too and all that sort of stuff, but quite quickly working out, it's not working here. It's, it's too much information. It's too detailed. So no, I've really enjoyed this. I've really enjoyed how you laid this out. And some of the things I've heard, the theory of change and that sort of thing I've heard about, but I've not used it. So I think, yeah, this is really good. And I've just got a new role in One Care, which is the GP's Federation in Bristol, as a kind of change project manager, trying to embed things that we're putting out, trying to embed them and help general practice embed these things. So the stuff you talk about at the end is what I'm trying to. My new role will be, which starts today, actually. So
congratulations.
So yeah, this has been really, really, really useful to me to think about it a little bit differently.
Yeah, I think it's really interesting, isn't it? Because when I've done prints too and managing successful programs, it's so different to the way things work in the NHS. And we've got a lot of really useful project management courses and resources, but I think it's really difficult to drill down and know which ones are useful and which ones aren't, which is why I've tried to make it really, really simple and direct people to the ones that I use. But it is trial and error. So just because you like something doesn't mean that somebody else will like it. And I can see Judith as an experienced project manager. You kind of have your own quirks, don't you, Judith? And just because I love PDSA cycles doesn't mean that it'll necessarily work for you. Amy, I was conscious that you had your camera on. Did you want to say something or?
I was just confirming that we're still here and still listening, and I hadn't heard of a lot of those, any of those tools that you were talking about, so that was really useful to be made aware of them. Where can we access those? Are they on?
So I have put all the hyperlinks on the slides, so you literally just need to click. So again, it's so confusing because the NHS is constantly changing. I used to access them all through something called the NHS Institute. I don't think that exists anymore because the HEE merged with NHSE. So sorry, Health Education England merged with NHS England, and NHS Institute disappeared. So when I was just putting together the slides for this presentation, I found all the links on something called Aqua. I'd never heard of Aqua. I don't really know what it is, but it's the same thing as the NHS Institute. Is exactly the same documentation. So I've put all the hyperlinks on, but there's a load more resources. I mean, I could have just spent the entire presentation giving you more resources. So I've just taken a selection of the ones that I particularly find useful for, but just literally click on them.
I think thank you. I think that's really cool. I was just going to say, in terms of what I struggle with is documenting it as you go along and having a nice, easy way to make sure all the progress is documented. I think it sounds really helpful for that. And just clarifying really clarifying the aims and how you're going to measure things as well.
Yeah, I think that's where I struggle with prints too, because I find the documentation takes over. So Prince 2 is like a very formal management training process, and there's so many things that you have to fill in that actually it feels like that's the project in itself, just filling things in. So I like to keep the documentation really simple because there's often your funders or somebody from an exec on the integrated care board isn't going to read masses and masses of documentation. So the documentation is just for you. What I use is stuff that supports me in my project management, but also in my reporting. And that's why I love the logic model. So it's just a plan on the page. So it's literally a one pager of an overview of your projects, and you can send it out to everyone. So Kerry's on the call now, and she's my line manager for my NHS job, which is across the southwest. And I've used a logic model for that job, and I've literally sent out the logic module, but which I don't call a logic model, I just call a plan on a page because it sounds less scary. I've literally sent it out to every single person that I can think of in the southwest, and it's just really helpful because then you're just, it's like a bit like advertising, isn't it? You're saying the same thing again and again in a really simple and almost like infographic way. I think I can't overstate the importance of simplicity and lack of documentation in some ways, although you do need some, but don't get carried away with it. Kerry, did you have any questions? Or
no, I think it's really helpful, Kate, actually, because I think from my sort of feedback, we get quite bogged down, like we're clinicians, and then all of a sudden we're asked to do sort of project management of things, and I think that we get bogged down by having to undertake a specific project management course to hopefully give us those skills. And I think that it's just been really useful, the information that you've shared. I definitely will be utilising it, and I think it's your logic model definitely has been like very easy to follow and very easy to use. And I suppose, like you say, get rid of all of the noise and effectively just focus on a couple of the tools that you've sort of provided, and making sure, particularly around sort of terminology, I think it's the key, isn't it, around making sure that the wording that's within that is that you're not using abbreviations, that you're using sort of things that people, if anybody picked it up, like my dad picked it up, who's non-medic, could read it and go, oh yeah, I know what that means. And then it makes it easier to follow, because actually ultimately the roles that you're doing and the projects that you're doing are around professional and public safety. So you need to make sure that that's sort of identified within that as well. But no, thanks, Kate. Sorry, I had a push bike crisis. I had to just try and manage in the school holidays. That's just run outside.
I wondered if everyone,
you know,
I wondered if everyone had that, because teenagers shout off, don't they? And you have to go.
Yeah.
And, yeah.
No. But I thanks, Kate. I think that it was really helpful and very useful from my perspective as well. And sometimes doing courses, maybe they're good if they're the role that you're employed to do, and that's part of your sort of role. But as a clinician, it's finding the right sort of tools that are available to everyone.
Yeah, and again, as Judith and I were saying, it may well be, as a clinician, we like to use different methods. There are different ways of doing things, and it may be that you find something that suits you, but it's just not getting too bogged down in the documentation. Yeah, brilliant. Any other questions or comments? Well, it's really lovely to see you all.